today at CSICON 2019. I am Dr. Rahul Kotwal from medical team of Medlive Pharmaceuticals, and we have with us today Dr. Professor N. Khanna with us, who is Senior Consultant and Head of Cardiology and Vascular Services at Indrapastha Apollo Hospitals, New Delhi. He is also an advisor to Apollo Group of Hospitals in India. Sir has delivered a session on degenerative valve disease. So first and foremost, we welcome you to the channel, sir, and we also thank you for accepting our proposal for being the part of the channel and providing the description of your session. So sir, moving ahead, I would like to ask, how common is degenerative valve disease in India?
Rahul, this is interesting because if you see the pattern of valve disease in India and abroad, in the Western world, the valve disease is usually degenerative. 95% of the disease is degenerative. In India, 90% of the valve disease is rheumatic or inflammatory in origin, and only 10% is degenerative. But having said that, what is going to happen in the next 30 or 40 years? Right now, the Indian population is young. When our middle-aged population and this population ages, we will have much more of degenerative heart disease because our population is big. And if you sort of, see it in coming future, what is going to happen is we will have, in terms of numbers, we will have much more patients of degenerative valve disease than anywhere in the world. But right now, it's only 10% as compared to 90%, which is rheumatic. Also, because of better treatment facilities and sanitation of the people living in India, what is happening is the incidence of rheumatic heart disease is coming down as we go forward, and it is the degenerative disease which is going up. Now, today it is 90 and 10% degenerative, 90% rheumatic, but what I presume in the next 20 years it will be almost equivalent to 50-50, and maybe another 20 years it will be 80% degenerative and 20% rheumatic.
Right, sir. So, what are the different types of valve diseases?
Okay. So, as we know, there are 4 valves in the heart. 2 are the semilunar valves, which are the aortic valve and pulmonary valves, and there are 2 valves, which is the atrioventricular valves, which are mitral valve and the tricuspid valve. When we talk about degenerative valvular disease, usually it is commonly seen in mitral valve and aortic valve. Most common in aortic valve, least and less common in mitral. Very unlikely in the right-sided valves, which is tricuspid valve and pulmonary valve. Now, the way in aortic valve, the most common disease is degenerative aortic stenosis, which is seen in 2-3 subsets. One subset is when the patient is born with an abnormal valve, which is a bicuspid aortic valve. Normally, the aortic valve is tricuspid, that means it has 3 leaflets. The bicuspid valve will have 2 leaflets, and because of that, there are eddy currents which are formed inside the valve tissues, on the valve tissues, which act because it's not opening centrally, it is opening eccentrically. The valve leaflets get damaged over a period of time. They become thick and stenosed, and it leads to an early degeneration leading to aortic stenosis in bicuspid valve. So that's the first variety of degenerative valve disease, which is congenital but which has early degeneration. The second variety is when you have a congenital myxomatous deformation and inflammation and T-cell infiltration into these aortic valve tissue, and this leads to thickening and calcification of these valves. And it leads to, when these patients grow up to an age of 60 to 80 years or 90 years, they would develop a very thickened and calcified valve, which is tricuspid, normally to start with anatomically normal. This is the second type of degenerative aortic stenosis. And third type is when you have, because of aging process, the mitral annulus and the aortic annulus, which we call the mitral annular calcification, develops as a generalized response of calcification in the body, and the aortic valve also gets secondarily involved. So these are the 3 types of aortic valve, degenerative aortic valve disease. Coming on to the mitral valve degeneration, you have about 15% of the patients in Western world would have degenerative mitral valve disease. But the good thing about it is the mechanism is same. It's a myxomatous tissue degeneration with calcification of the mitral valve apparatus, which could be leaflets, chorditendinae or papillary muscle. But what happens, the good thing is that it is never severe, and very, very rarely it demands any surgical or interventional management.
It was really informative, sir. So moving ahead, what are the treatment modalities on degenerative valve disease?
Okay, so the treatment modalities would be similar to any sort of valve disease. The classical treatment is medical therapy till it warrants surgery or intervention. But when the patient becomes very symptomatic, especially in aortic valve, if we talk about aortic valve, if the patient starts having angina because of severe aortic stenosis or starts having aortic low output and syncope because of aortic stenosis, or if there is heart failure, in this sort of situation the patient requires intervention or surgery. Now how we sort of decide between surgery and non-surgical treatment, which is replacement of the valve through non-surgical route, which we call as a TAVI or TAVR. If the patient, there is a team of cardiac surgeons, anesthetists and doctors which we call as a heart team. We evaluate these patients based on the frailty index of the patient, comorbidities, and also on the anatomical type of the valve, takeoff of the coronary arteries, which we assess by CT scan. Then we assess whether this patient has a higher risk for surgery or is suitable for TAVI. If the risk is high, which we calculate by Euroscore, if the Euroscore is more than 6, then the patient has suitable anatomy and the femoral vessels are of adequate size, we send these patients for TAVI, which is now a very standard treatment for high risk and intermediate risk patients. But if the Euroscore is less, that means the patient's risk of perioperative risk for surgery is low, then these patients do better with surgical valve replacement. So there are only two ways you can treat. One is medical therapy or a valve replacement, and the valve replacement can be done surgically or by TAVI, which is a transcutaneous non-surgical approach of replacing valves. The second part is for mitral valve. Now mitral valve, when we are treating, we are actually treating not the mitral stenosis but mitral regurgitation, which is a more common form of degenerative valve disease, which usually happen when the patient is born with mitral valve prolapse, and slowly the mitral regurgitation increases over a period of time. And if these patients become very symptomatic and warrant treatment, in those sort of situations, if the patient is high risk for surgery, we can actually we can put a stitch, a percutaneous stitch or a clip, which clips the anterior and posterior mitral leaflet and decreases the orifice for regurgitation, and brings down the mitral regurgitation and improves the hemodynamics of the patient. And it is done under conscious sedation. It is done by a venous route with a transseptal puncture, and here the patient can be discharged very quickly and without any major perioperative issues or complications.
Well said, sir. So you mentioned about TAVI and mitral clip. So what exactly is this, if you can just elaborate?
Okay, TAVI is it's percutaneous or transcutaneous aortic valve replacement or implantation. What we do here is we have the patient sedated. We have a valve which is mounted on a catheter, and it is sheathed inside a sheath. So when it's a self-expanding valve, when you open the sheath, it will actually open up, and which has a valve built inside. It's a spring which has a valve and will start functioning as a valve and stay there in the aortic position. The other type of aortic valve, which is a valve which is mounted on a balloon, and this you take this valve and a balloon assembly to the place where the aortic stenosis is, that means the native aortic wall, and you dilate the balloon. So the balloon dilates, and when it deflates, the stents open and oppose the native aortic wall, and there is a valve inside which starts functioning immediately. So it's like a stent. Both actually are stent. The first one, which is a self-expanding stent. The second one is a balloon expandable stent, both of which valve is mounted and which starts functioning as soon as you put it. So there are two ways you can do this, and once this is done, immediately the valve functions on the table and the procedure is complete. This is done in the cath lab under fluoroscopy guidance, just to locate where the valve has to be put and where the coronaries are. So it's not a very long and big and tedious procedure. People who do vascular interventions and aortic intervention, it is a very fast and a simple procedure, but it requires a good planning of which valve to put and what should be the hardware and technique. And sometimes, rarely, these patients would require, they would stretch on the conduction tissues and would require a permanent pacemaker implantation. The other one is mitral clip. Now what we do in mitral clip is we go from the venous side, like we do a balloon mitral valvotomy. We go from the femoral vein, we go to the right atrium and focus on the interatrial septum, where we do a guided puncture under fluoroscopy or echocardiography, and through that, once we dilate and make an opening in the interatrial septum, we negotiate a catheter which has clips in it, and under transesophageal echocardic guidance and fluoroscopic guidance, we actually clip the anterior and posterior mitral leaflet to reduce the orifice. So these are very simple techniques, but the only thing is the cost of the treatment is much higher than the conventional treatment, and I'm sure with rising number of patients and over a period of time, these are going to be down regulated to their correct prices, and more people would require it. But again, if you compare the Indian number of valve replacements done percutaneously as compared to the Western world, we are far behind. One, because of two reasons. One, that the cost is high, and second is that we have more of rheumatic heart disease where this is not an indicated procedure, and very little or much less of degenerative valve disease.
That was really very informative, sir, and I also am certain that even audience has gained very much valuable insights and guidance from this session. So I really thank you for being part of this session, sir. Thank you very much.